My name is John D. Kelly IV. I am an associate professor of orthopedic surgery. I am actually an orthopedic psychiatrist. I'm a bonehead. So your name Kelly is Irish, but my mother was Lebanese, so I'm half Irish, half Lebanese. I'm really an alcoholic terrorist. My real name is Osama bin Loaded. And this fellow here is not laughing, but we'll get to the rotator cuff, don't worry. Anybody out there know what the rotator cuff is? My mother, God bless her, 86, she told me her age. She would never tell me her age till recently, but she did tell me her social security number was 4. And her driver's license was in Latin. These are known as jokes, ladies and gentlemen. And that is not my full-time job, okay? It's not my, it's my, oh, all right, who's this fella here? Reggie, get him, my bodyguard, Reggie. Reginald is my, can you stand up, Reg? This guy is a former wrestling coach, no, still wrestling coach, former Miss Philadelphia. Give him the double arm crab. Give the audience the crab here. He's going through withdrawal. He had to stop steroids this week for personal reasons. But so what is the rotator cuff, young lady? You raised your hand. What is it? Yes.
It's your shoulder and it controls all the movement of your shoulder, your arm.
Yes. So it rotates the arm, and it's a cuff of tissue around the shoulder. So rotator cuff, and there's basically 4 muscles. Hi, come on in. You missed the first course. The second's going to be served in a minute. Yes, we're at the beef burgundy stage. So the rotator cuff rotates the arm. And it turns out that God gave us 4 muscles, and one of them seems to tear more than others. And anyone out there over 40? All right, why do we get rotator cuff tears with aging? Well, this is my friend Irish Sean. Who's a great, Sean Laughlin. He's a former Irish freedom fighter. He's going to take a collection for the IRA later on, but Sean and I recognize that the word degeneration comes into play. You know, we do get older. That's a fact of life. Doesn't mean you have to get worse. The golden years are true, right, Reg, in some respects? But I do think that, you know, some things lose blood supply as we age. Nothing wrong getting older. I'm 53. And I feel pretty good except for my joints. My joints hurt. I still feel good, but when I get up in the morning, I need a can of 3-in-1 oil just to walk. But some things do lose, most of the vessel-fed muscles in our body do lose a little blood supply. So as we get older, our rotator cuff gets a little, we call it degenerative. Loses a little bit of vascularity, is more prone to injury. And if something that can recover at age 18 is not able to recover at age 40, you get these little small, little traumatic micro tears that occur. Next slide, Sean, please. So we're going to talk about shoulder pain in adults. The most common cause is rotator cuff and adhesive capsulitis, and you get arthritis. For tonight's talk, we're going to focus on the rotator cuff. So tendinopathy, a tendon is something that joins a muscle to a bone. So we have 4 rotator cuff tendons, and the tendon moves the shoulder and attaches to this bone called the humerus. Now, this is a picture of the supraspinatus, so almost all tears start at the supraspinatus. Why is that? There may be some vascular reasons why that one tendon tears. It happens to be an area of high stress, and it's the one tendon that sits under a bone called the acromion. That's the supraspinatus. This is a look of the arthroscopic picture inside the joint. That's the biceps tendon there. So that's one of the first things you'll see. And it turns out that the rotator cuff tears on the deep surface first, usually. Then the tear can propagate and become full thickness. So if you want to think of it in terms of a spectrum of injury, tendonitis, which many of you may have, then goes to partial thickness tear, and the full thickness tear. Now that's important because most people with partial thickness tears or tendonitis, I send to Irish Sean. They don't need surgery because most people get better. The other thing I want to tell you is that some people, even with a full thickness tear, don't need surgery. Go to Irish Sean. The problem becomes, one of the greatest things in medicine I love so much about it, not only do you help people every day, but the creativity involved, it's an art. And one of the arts of medicine is who needs an operation. And we're going to talk about that tonight, who needs surgery. Truth is, most people don't. Most people don't. So we go to the next slide, Sean. So these are the 4 cuff muscles, and number 2, 3, this is the one right here. the supraspinatus, the one on the top. It's under a bone called the acromion. When we raise our arm, that's the one that contacts that bone. That may be maybe one reason why that supraspinatus gets beaten up, because it's under the bone and attaches or contacts the bone, what we call forward flexion. Next slide, Sean. And you can get degeneration in time, and you can get a little Arthur. Anybody know who Arthur is? It's a Philadelphia term. You know who Arthur is, ma'am? And his cousin, Ritus. So I have some wonderfully creative patients in West Philadelphia. You walk in the room and say, "How can I help you?" "Sir, I had a visitor last night." "Oh, yes, who came to you?" "Arthur. And he brought his cousin, Ritus. And once Arthur moves in, he never leaves." A lot of wisdom now. Once Arthur moves in, there's no cure. Despite what you may read in the lay press, there's no cure for arthritis. There's no arthritis cure. Maybe we can slow it down. We can't cure it. So you'll sometimes see a little arthritis. This is the sac of tissue called the bursa. And one of the reasons why our shoulder hurts so much, the bursa also gets inflamed. The cuff tear itself may be painful, but it also causes inflammation of the bursa. And that's why the cortisone shots give you relief. Calms down the bursa. We'll talk about cortisone shots, good, bad, and the ugly. Next slide, please, Sean. So impingement is really the process of where that cuff tendon rubs against your bone called the acromion. And over time, if your cuff gets a little weaker, one of the things the cuff does, it makes that motion smoother. And if the cuff gets weaker, then it actually starts letting the humerus ride up, and that impingement can occur, and you can get actually more contact, more fraying, more tearing. So my old friend just came in. So this next slide, please. This is impingement. So just think of it this way. When God made our cuffs, the supraspinatus muscle is right here, tendon, under this bone called the acromion. Now, some people were born with bigger acromions and narrow outlets. So when God made acromions, you either have a flat one, a curved one, or a hook one. People with hooked acromions are more prone to get impingement. That's just the way you're born. And sometimes you'll see a hook like that in that bone. This is the tuberosity, this is the acromion, and there's a little narrow space in this person. This person has less breathing room for their cuff. You may also be born with a prominent tuberosity bone. So anything that's going to narrow that distance may make you more prone for impingement. Next slide, Sean, please. And now sometimes you don't even need a bony problem. When you walk in the room, if I walk into the room and I see a patient and they say to me, "My shoulder hurts," look at my posture. Now I want you to all sit in your chair right now, lean forward like this, like I am, and raise your arm forward. Everybody. All right? All right? Look at that person in the back grimacing. Now, my father was a Marine. I want you to take the Captain Kelly posture, sit back, shoulder blades pinched, raise your arm again. Look at the difference. So what you've just done is you've gotten your acromion out of the way of your rotator cuff. So someone who has poor posture like this is literally bringing their acromion closer to the cuff just from non-outlet, just from dynamic reasons. That's why we send people to Ira Sean, because he can train you to use your scapula, to retrain your scapula, to find that position where it gets out of the way of your cuff. So one of the best positions of posture, my dad was a Marine, is when you stand it straight, hands by your side should be right along the shaft of your femur. That's good for your neck as well, too. So, posture can also cause impingement. Next thing, look at this fellow here. Chief complaint, "My shoulder hurts." Next slide. That's what we call protracted scapula. Scapula comes forward. Remember Jackie Gleason? How many people remember him on TV when he would drink whiskey, go like this? Wow! Did you spike this, Sean? Next. So this is a fancy slide, but basically, if we have poor posture, our scapula can actually move out of position. And if you keep that posture long enough, the muscles can contract, and you can have a statically poor posture. This generation of bodybuilders and athletes, the coaches are in this bench press mania. Everybody's benching. You see the kids in the wrestling team, Reg. How much can you bench? Well, they've neglected their back muscles, so you get these overdeveloped pectoralis major muscles, and they walk in a room like this. You know, they look like Gorilla Monsoon, but they've never done any trap or serratus or any kind of scapular retraction exercises. And if your pecs are overdeveloped and there's nothing to balance it out, you end up with this posture, then the soft tissues contract, and it's hard to get them to stretch out. Because what they're really doing is they're potentiating that impingement. They're bringing their shoulder blade forward, closer to their cuff. Next slide, Sean. And you can train those, and Sean could take a patient whose shoulder blade is way like this and give him some stretches. One of my favorite stretches, and the name of the stretch is a little suggestive for women. I hope I don't offend you, but it's called a hey big boy stretch. In the old days, this guy smile in the back. Woman will come up to you, hey big boy, look at my hands in my pocket. And that's bringing my shoulder blades back together, stretching out muscles, one particularly called the pec minor. True story, I'm an identical twin. I have an identical twin brother, good looking guy. And one day I was at a bar, and this is a true story, and some woman came up to me and basically did a, hey big boy, hey there. I'm like, do I know you? She was really cute too. Turns out she was dating my twin brother. She thought I was him. But she did the, oh, hey big boy. And I was like, I don't know you, but I wish I did. Next slide, Sean. So, oh, I'm sorry, this is it, yes, hit the clicker. So how do we know if you have a rotator cuff problem? Well, one of the two universal things I ask patients is, does your shoulder hurt at night? And is it worse when you lie on your shoulder? Anyone out there have those two symptoms? Yeah. Is it worse at night? And does it hurt when you lie on your shoulder? Now, the Lord knows why that's the case. I think the pain at night maybe due to something to the fact that the bursa is inflamed, and most inflammatory conditions are worse at night. How many people out there have had children? What? Children have kids. Anybody raise kids out there? Oh, yeah. When does fever strike the worst? Nighttime. Inflammation, whatever reason, body's natural mechanism, seems to get worse at night. If, God forbid, if anyone ever gets a bone cancer or an infection of the bone, pain is worse at night. One of the questions I ask patients almost all the time, is your pain worse at night? If it is, usually it's an inflammatory component. Pain lying on the shoulder, probably because you're lying, you're irritating the cuff, or you're compressing the cuff against those bones. Those two things, if they have those two symptoms, they almost always have a cuff issue. That's a new word for this decade, issues. I got issues, you know. I'm Irish Catholic. I was raised by the nuns. I had Sister Idi Amin, third grade. She was 27-2 with 26 knockouts, you know. Remember those days? Anybody there raised by the nuns? When time out was the time you were out cold. Remember that? You're talking about concussions. Boy, I had about 6 in third grade. But anyway, make a long story short, how did I get over that? Well, how did I get into the nuns, a Catholic thing? But I do a PhD in guilt, you know, from that formation. And I do thank the nuns for all the good things. But my guilt is so bad, Reg. Last week I did jury duty. I spent the whole week trying to convince the other jurors that I did it. You want me? I'm guilty. But to make a long story, next slide, pain over activity. And now, whatever reason, when I learned in medical school, people with angina often go like this. They clench their chest like this, or arm pain. That's often, they call it Levine sign. Well, if someone grabs this right here, and they say my shoulder hurts right here, that's almost always a cuff issue, an issue. I know what I mean, issues. So everybody has issues. So I said I have issues because of the way my formation. But I have people come in the office now, and my first line usually is, hi, John Kelly, how can I help you? I have some issues with my shoulder. Issues? Why don't you say my shoulder hurts? Do you have issues with your shoulder? Did your shoulder abuse you when you were younger? I mean, that's the new, I just know that's the new word of the decade. You notice that, Care? Yeah. Okay, we're going to go through some of these tests. Next slide, Sean. One of the things, I want you everyone to put their thinking cap on. When your shoulder hurts, you avoid things that hurt, right? And one of the things that seems to be most painful for cuff patients is reaching behind. Young man here, you're shaking your head when your cuff hurts. So guess what? We don't reach behind. It's like the old Henny Youngman joke. I went to the doctor. He said, my arm hurts when I do this. Don't do that. Well, we do that subconsciously. We don't reach behind because it hurts. So in time, we often get what we call posterior capsule tightness. Reaching behind stretches part of your shoulder called the posterior capsule. When the posterior capsule gets tight, it makes things worse. You got a ball and socket. The back part of the ball and socket joint gets tight. It pushes the ball forward. And when it pushes the ball forward, it pushes against this bone called the acromion. So posterior capsule tightness can make the impingement, the cuff irritation, worse. So someone like Sean can actually stretch the posterior capsule like this and make your shoulder more supple, do it in a gentle fashion, so the ball and socket, instead of being like this, sitting forward, it's more balanced. Next slide, Sean. That's because when we call it capsular constraint, if one part of the joint's tight, it pushes the ball forward. And this is called the near test. Raise your arm, and this is where the cuff is hitting that bone right about here. And that usually hurts overhead. Next slide, Sean. So if someone has pain like this, a night pain, we give them a little, we call special sauce, a little Novocaine, lidocaine, and some steroid. The near test is if that gives you at least 80% or so relief, that's your cuff. We inject some Novocaine in the bursa, and if it gives you relief, that's what you have. Now, my philosophy on injections of cortisone. Cortisone gets a bad name, but I think I've personally saved many people from going to surgery by cortisone. Judicious, judicious. If someone is 85 years old and does not want surgery, I'll give them a cortisone shot every 3 months or so. What's the downside of cortisone? If you give too much of it, A, the person may use his or her arm and cause more damage and not know it, and B, some animal studies show it makes the cuff a little weaker. So I'm not a big fan of it, but it's one of the last option I'll do that. If I think someone may need an operation in the future, I'll tend to shy away from cortisone because I know it weakens a tendon and it may actually inhibit the repair response. God gave us inflammation as part of the healing mechanism. If you suppress it so much with cortisone, it does delay healing as well. So cortisone gets a bad name, and some of it's justified, but other times, you know, it's a good thing. Now, my friend Carrie over here, we worked at Temple together. That was the cortisone capital of the cosmos, and I had a lot of people that actually saved from getting surgery. But I think in retrospect, I probably maybe overdid it at times. Anyone out there diabetic? Anyone else? We have pretty low numbers here, but diabetics, if you have a cortisone shot, expect that your sugars will go up. Cortisone does that. Okay, next slide. Now, the tears usually start at one location, usually one location, at the supraspinatus, and they usually propagate either in the front or the back. So next slide, Sean. This is the test I use. This tests the spot of the rotator cuff. The tears start most frequently. Can I ask my friend Reginald Van Gleason to demonstrate? Reggie, want to stand up, please? And I'll tell you, Reggie, I'm not going to tell you his age, but I'll tell you, this guy is a specimen. Look at his guns. What time's the gun show? When does it start? Okay. Now, Reggie's going to face the audience. Say hello, people. Hello. Now, keep your elbow straight. Bring it over in front of your arm here. Now, watch this. Do you ever, which shoulder hurts? Don't tell me. Hold up like that. Hold it up. A little weak. Now, see, start recruiting his trapezius. For a big guy, now watch this. Elbow straight. Bring it over like this, Reg. Over, over, over. Hold it up like that. Now, from his exam, I can tell he has two things. He has a weak right shoulder, a cuff issue, and arthritis in the right shoulder. And a little crunching, like the ratcheting, little bone abduction. Now, this is a pearl number 36. I learned from athletic trainers over the years and therapists. They teach me things. One of my old friends named Jim Rogers told me that he's never seen anybody, a man, lift heavily and not make it through their 50s without a shoulder issue. I was in the lifting thing for a while. My left shoulder's killing me. He's got arthritis in the right shoulder. You probably bench pressed the building at one point, didn't you, Reg?
Actually, I was vacuuming the rug for my wife the other day, and that's what hurt it.
Well, I don't think vacuuming the wife gave you the arthritis. Nice try, Reg. Trying to get out of the house. Thank you very much. That's a nice little pearl, though. Those of you that are over 40 or 50 and want to lift weights, take it from me. Go easy. Forget the Arnold look. Talk to your husband or wife, say, you know, do you love me as I am? Do I need to have the beach muscles? But Jim Rogers, a lot of wisdom. Never seen anybody lift heavily and make it through their 50s without it. I see a lot of guys coming in, you know, and they just don't want to, as my old teacher, Dr. Lockman, would say, you have to shake hands with your condition. That means embrace it, accept it. A lot of people just don't want to embrace the fact they have a little arthritis, and they refuse to give up lifting. Refuse, right, Carrie Beth? Sean, you see it all the time. I have people coming in, I got a bench. Why? I just have to. Well, if it was a question of getting a shoulder operation or giving a benching, that's a no-brainer. I give up benching. And even if we do the shoulder surgery, you're going to blow it out again. So we're trying to be sensitive about it. So This is another demonstration of the Whipple test. Next slide, Sean. Now see if we play this video, Sean. Put an arrow in that. Now this is going to show you a test to see if the shoulder blades are positioned properly. Now watch this shoulder blade. Now watch how this young man, when he lowers the weight, watch his shoulder blades kick out. Boom, look at that. So he has some shoulder blade weakness issues that a good therapist can address. Next slide, Sean. So when the shoulder blade kicks out, it gives you a higher chance. This is controversial, but my belief is that everything in life should be balanced. When the shoulder blade kicks out, you have more chance of doing this. I just talked to Marty Kelly. You know how he feels about scaphodyskinesis. So what do we do when you come in the office? You get an X-ray, MRI, only if you don't respond to PT. And I get my Irish up when, I try to do my little thing to keep healthcare costs down. MRIs have such a great name in the lay press, but they're not really the end-all be-all. My old teacher would say, that person needs a man scan. Do a physical examination. MRIs are about $1,300. Some of your plans require 20% copay. That's a lot of cabbage. And I always order a test saying, is this test going to change my treatment? You come to me first visit, I'm going to give you some rehab. See how you do. You may do great. Why do I need an MRI if I want to treat you the same way anyway? So the whole healthcare thing has changed. We're asking to see more and more patients. So some doctors, well-intentioned, instead of examining the patient, say, get the MRI and see Kelly in a week. I hate that. Did anyone ever examine you? Anyone ever talked about your problem? Now, plain X-ray is important because that'll rule out arthritis. Reggie has pain in his right side, and you would think on the surface, hey, he's over 50, barely. He's got a shoulder problem, got a rotator cuff. Well, what if it's arthritis? The treatment is entirely different. I said to Sean, with the arthritic, Sean's going to be real kind and gentle and do stretching. He's going to avoid strengthening because he knows strengthening is going to make the arthritis worse. If it's a cuff, a whole different game plan. So it's important to know whether it's arthritis or cuff. Treatment is entirely different. Next slide, please. So this is an MRI, and again, I get MRIs if someone fails rehab or if there's something questionable about the examination that makes me think, am I dealing with something else here? We do see bone tumors, unfortunately. If someone has unremitting pain at night, maybe a fever, chill, think of osteomyelitis infection, or pain that's crescendo, getting worse and worse and worse, and you can tell, and I've seen people with bone tumors, and it's not a pretty sight. They're just in agony. Then I get an MRI scan right away. So here's a rotator cuff tear. It looks like the tendon is pulled off the bone. That's a small tear. See the fluid? That's a bad tendonitis, partial tear. This is a small tear. Next slide, Sean. This is a bigger tear on the left, and this is a massive tear on the right. The tear is actually retracted all the way back to the socket called the glenoid. So, next slide, please. One of the reasons we do surgery is, actually go back one, Sean, if you don't mind. One of the reasons we do surgery in some people that don't do it with rehab is because I don't want that to become this. Because when it gets that big, two things happen. Number one, it becomes retracted and hard to get back in place. Number two, once it's torn off the bone, it loses blood supply and gets atrophic and gets thin. So even if we fix it, it's still never going to be as good as it was before. That's called fatty atrophy. It's just a fact. Well, no one really knows why it happens entirely. Although I did read an article recently that people who have high vitamin D levels get less atrophy. I'm a big vitamin D fan. It's great. It helps prevent cancer, osteoporosis, and helps with ADD. I have something called attention deficit hyperactivity disorder. Now that's ADHD. That stands for attention deficit. That's a nice shirt you have there.
Back on track.
Thank you. Yeah, I'm glad this guy got the joke. Come on, Doherty, give me some laughs, will you? So make a long story longer, the reason, the art of medicine is who needs to get their cuff fixed. So let's get to the nitty-gritty of this talk here. If someone is a strong person, requires a strong arm to do their job, I know that if the cuff is torn, they'll never get their strength back. That person needs an operation. If someone has really bad tendonitis or a partial tear and has seen a good therapist like Sean, after 3 months, 4 months, they're not better, not sleeping, they need an operation. If someone has a cuff tear that involves more than one tendon, that person will need an operation, because I've never seen, when I shouldn't say never, but generally speaking, the two tendon tears, the bigger tears, are the ones that retract and become atrophic fast. There's something called rotator cuff arthropathy, which is a term we use to describe people who get arthritis from a cuff tear. Think of it, you got the ball and socket, you got this cuff covering it, and with the cuff being torn, the ball starts riding up. Look at the shear stress across the joint. So people with big cuff tears in time will get arthritis, and arthritis is forever. So pain that's not responding to rehab, someone who really requires a strong arm for the job, a laborer or an athlete, or someone with a two tendon tear. Those are people that I tend to recommend surgery. Now, everything is, gray. There are some people that just refuse an operation. I don't want to get this fixed. Okay, let's make the cuff muscles that you have left stronger. One of the sad truths is rotator cuff tears don't heal. They don't. Once they're pulled off, they never connect by themselves. So Sean, let's breeze through some of these slides. So let's just talk about the non-operative treatment before we finish up with the surgery. Send you to Sean. What Sean's going to do, he's going to strengthen what's left. He's going to work on your shoulder blade. He's going to stretch your posterior capsule, and judicious, I use the word judicious injection. It does weaken the tendon. Next. And this is one exercise I love. Of our 4 cuff muscles, this is using the infraspinatus, which is this one here, that rotates out. And if you want to see if someone has a big cuff tear, if they lose this strength, that means the cuff tear, which usually starts at the top, has now spread in the back. 2 tendons, maybe 3. I love this exercise because even if you have a partial infraspinatus tear, if you work on whatever you have left, most people will feel better. What's wrong with this picture? Look at the asymmetry of the scapula. Someone like Sean can help you maybe reduce that scapula, get it positioned back, so get that shoulder blade out of the way of the cuff, feel better. Next slide. This is called what? Sean, tell them what this is.
It's the sleeper stretch.
And you want to tell them why it's called a sleeper stretch?
It almost looks like you're sleeping. You're sleeping.
Or do you fall asleep during the exercise? Nope, not that one. Because this is a little painful. You don't fall asleep because you know why? It's a little sore. What Sean is going to do is going to have you lie down on the table and stabilize your shoulder blade, so he's focusing on just the shoulder ball joint. And Sean, you want to demonstrate right now? Sean's going to lie on the side. He's going to show you how to do this. If you could take away one point from this night's talk, if you do a posterior capsule stretch, you have to excuse Sean. He's working under a big handicap tonight. He's sober, so just bear with him, okay?
Yeah, you're keeping your weight on your shoulder blade, keeping a 90-degree angle with your arm from your trunk, and then you want to slowly press that arm away. You're going to feel stretched down your arm right through it. Make sure your arm doesn't go this way, or that you come off your shoulder blade, so the shoulder blade stays still, right angle at the elbow as well as your trunk, pressing down like that.
Where do you go?
Excuse me?
How far do you go?
Normally you want to see about 66 degrees, about 2/3 of the way. You can see I'm pretty tight here. I'm probably closer to 45, so 0 would be here. If that went straight down, I broke my arm. Okay? So usually when I'm measuring for normal range of motion, I usually look for about 66 degrees. I don't know if you feel otherwise. That's what I kind of look for, 2/3.
And just for some pointers, Sean, how would you recommend that they do this and how many times?
Sure. Typically holding-wise, I like a longer duration stretch, so at least 10 seconds. I like to get 20 seconds, that's better. Anywhere between 5 to 10 times. 2 to 3 times a day. But I'm very careful regarding the reactivity. If this is painful, I'm going to go back off and go a little bit easier. This might not be the best stretch for you. But this is a great preventative stretch too. Again, I have all my throwers and my young baseball players really stretching that out and to try to prevent injury.
If you have trouble, males tucking your shirt in, women fastening your bra, this is the one you want to do. Look, can't reach behind. And as I get older, I realize the importance of stretching. Athletes like Reggie know that I think you got to stretch. As you get older, you get a little weaker, but you also get stiff. If you do this exercise, within 2 weeks, you'll probably notice a significant just mobility. Reach behind the back seat. Hey, I can get my bra strap, I can get my shirt in. So it makes a big, big difference, at least in function. Thanks, Sean. Oops. So, okay, this would arrow. I'm computer illiterate. I'm a bilingual illiterate. I can't read or write in 2 languages, Reg. This is called a low row. This is a great exercise for just shoulder blade retraction, low row. Get it? Low row. If you do the sleeper stretch and the infraspinatus strengthening and practice posture and work on those scapular retractors, you will feel better pretty soon. Next slide, please. So, again, surgery. Who needs it? Failure of at least 3 months with a good therapist, not Joe's Bar and Grill or, and be careful. I'm not going to bash other cultures, but a physical therapist, not a podiatrist, not a chiropractor, not a massage therapist, not an acupuncture, not a shiatsu specialist. Those healthcare providers have their role, believe me. I'm not trying to trash them. But for shoulder problems, don't go to a glass-blowing, Rolfing expert. Capiche. Is that Italian, Reg? Capiche. Rolfing. All right. Active person, uterine tears. So we went through that before. Next slide, please. What's a massive cuff tear? I'll see these sometimes. If it involves more than one tendon, if it's over 5 centimeters in width, fatty infiltration means it's atrophic, and unstable force couple. That means it's such a big tear that your ball and socket has become unstable. Next slide, Sean. Let's hit this video here. This is a massive cuff tear. This is how they'll come in the office. Look at this. That's it. So let's hope and pray you don't get to this point. These are hard to fix. Okay, thanks, Sean. I just right clip. So I'm just going to go through some of the things that I'm a big, passionate arthroscopist. I think you can fix these things with the arthroscope instead of open surgery. And if you know the anatomy, excuse me, someone say something. So this is called a reverse shoulder prosthesis. Many people do this operation. I hate this operation. It's big, it takes away a lot of bone, and there's no turning back once you've done that. Now, don't get me wrong, some people need this when they have nothing else left. But I think if you just intervene before the cuff gets trashed, you can avoid that. And this is what we try to avoid. This is called fatty infiltration. This is what an MRI looks like when you've had a long-standing cuff tear. The body replaces that space with fat. And there's really nothing to fix there. Nothing to fix. I've been in the OR sometimes where you just kind of sew together Kleenex. I'm like, gosh, I wish I'd gotten to this person a year ago. Okay, well, thank you. So why do I use the scope? Anyone here, an older boy, take Latin? Anyone take Latin as a kid? What does veritas mean? Truth. So you get up in the morning as a physician, you say, what is the truth? Not what's an agenda. There's no word agenda in God's vocabulary. What's the best thing for this person? What's the truth? I think the truth is it's harder to see these things open. The scope gives you a better view. You can put it back where God made it anatomically, and it's much less pain in elderly with punctures versus incisions. So if you know where the tears belong, you can actually use the arthroscope. This guy taught me, this guy's in Texas, he taught me so many things about how to fix a cuff. He's a cowboy, he's from Texas, he's an engineer, he's a no-nonsense guy. He taught me these principles of biomechanics, force couples. I don't want to bore you with this, but basically, if you can get tissue balance around the shoulder and get it stabilized, it'll work much better. That's a force couple. Any engineers in the audience? Okay, a force couple really is moments acting around a center rotation to balance out. So it's all about getting balance in the shoulder. And this is important because you don't have to fix the whole cuff tear. If you can fix the business end of the cuff, you can restore balance. And Dr. Burkhart uses the analogy of a suspension bridge that it's suspended by just 2 points, yet the bridge stays intact. This engineer here hopefully can explain it better to me, but the truth is we can take a large cuff tear, if we can put it back on 2 important points, we can restore a lot of function to the cuff. You don't have to get it all the way fixed. That's the importance of that slide. So if you have a really, really big cuff tear, it turns out if you resolve the forces around the shoulder, if you can just fix the lower half of this muscle called the infraspinatus, you can actually restore a good amount of function and still leave a gaping hole there. But as long as you've gotten what I would call, like that suspension bridge, the business end of the cuff together, you can have someone come in the office like this and then have this post-op. Now, the truth be told, veritas, they're not going to be pitching for the Yankees. They're not going to win any powerlifting contests, but they can raise their arm. That's our goal. So there's different tear patterns, and you can see these patterns when you put the arthroscope in. And it took an Irish guy to figure this out, of course, McLaughlin in 45. He realized that the tears actually follow certain patterns, and if you recognize the patterns and know where the tear limbs go, some edges are more mobile, and you know where to put it back, then you can actually get a rotator cuff tear fixed with minimal tension. So there's different configurations of tears. This is more surgical, but this whole principle of we call margin convergence, bringing the cuff tear edges together so the edge comes towards the end. It's all about like really trying to put a puzzle together. So you can take a small tear. I had one of these today. This is pretty easy to fix, but you have a big tear like this. In the old days, we try to bring this to that, and now we realize, no, you got to bring these edges together. And you can see it real well with the arthroscope. So if you recognize the tear pattern and know where God made it, put it back together, then you can get a pretty good tension-free repair. Now I'd use the arthroscope, and I had the patients lie on their side like this. I put them in traction, and these are the portals we use, just a puncture, just arthroscopic punctures. So you can do the whole case with just 1, 2, 3, 4 punctures, sometimes 5. And what we do is we look at the cuff tear, and this person has arthritis, but you try to approach it 90 degrees to the tear so you can actually bring this limb to the back limb. And you actually can fix it if you know where it belongs, just like that. So this is a pretty beaten up tear of the subscapularis. That's the tendon in the front. And we're learning more about this tendon. We didn't know, there's an old, I think, Hebrew proverb that the eye sees what the mind knows. Think about that. The eye sees what the mind knows. Maybe it's Chinese. I may be getting my quotes wrong. We saw these tears in the old days. We didn't know what they were. We thought, it's a little frayed. Well, this is the subscapularis tendon. And we noticed that if you fix that in certain patients, they do feel better, and they have a longer, or they have a stronger shoulder long term. This is a subscapularis tear that looks kind of frayed. So this belongs up in here. And there it is fixed. So I brought the tissue up to where it belongs. That person's going to have more internal rotation strength. So these subscapularis tears really start in the front. They're commonly missed. And one of the ways you can tell is if you take your hand on your belly right now and just press down, if your wrist can stay straight, your subscap's probably working pretty well. If your wrist has to bend like this, then your subscap is probably a little weak. So this is a picture of a massive cuff tear that, thank God, I knew where it belonged. I put some traction stitches in, and we got it back. And look at this, how it's evolving. Big cue ball tear. Does this person need a new shoulder or a reverse prosthesis? I don't think so. We fixed the subscapularis, and then we brought it together. We got it basically covered anatomically. And this is how I shave off the bone. So whenever we do the surgeries, we take off some spurs. It's called acromioplasty. So this is taking a little like dental burr and just giving that cuff a little more space. So this is something that we do, and it takes about 5-10 minutes if you're really lucky, and this person will have more clearance for the cuff. This is a subscapularis again, and here we are just showing you how we fix this tear. So I put an anchor in arthroscopically, and this is tying the anchor down, putting the tendon back where it belongs, and cutting the suture. So here's a little video here of how we bring tears together. We're just actually passing it like a crochet needle through, so to speak, and there's our cuff tear, and we just feed a suture from the front, pull it through and tie it. We're just trying to put the puzzle back together. This is called a suture retriever, and you try to just be real gentle. And look how thin this tissue is. This is a chronic retracted cuff tear.
Tell me I'm asleep then.
What's that?
Tell me I'm not awake then.
Oh no, you're asleep. You're out cold. Out cold. I would never think of that. Now, some people do shoulder scopes under blocks and local. I think that's cruel and inhumane. So in terms of rehab, when we do this, one of the things I've learned with experience is go real slow. If you get a rotator cuff tear repair, for those of you who get that done, we really go slow with the rehab. I'm not a big fan of pulleys early on. Later on, yes. And I just have the patient stay in a sling for 6 weeks. So we're actually going to stop right there for questions. And we can, if we have time, we'll talk about adhesive capsulitis. But the bottom line with rotator cuff repair, it's an art, not a science. And I look at the patient, and if someone may be 65, but maybe physiologically 50, and they're active, the bar is raised now. 50 is the new 30. 30 is the new 50. No, 50 is the new 30. People that, if you look at the life actuarial tables, I had to look this up for another talk. If you make it to 50, you have about a 31-year life expectancy if you make it to 50. So if someone wants a strong shoulder and they want to play sports and they want to do lifting and so forth, we can let that cuff tear languish for a while, but I think long term they're going to be better off getting it fixed. If you have a cardiac problem, if you're on steroids, if you're on Coumadin, those are things that maybe make us think otherwise. The art of medicine is also determining which cuff tears are going to get worse. Some don't progress very fast. It all comes down to, it's really horse sense, but if you have symptoms of your cuff tear, someone did a nice study showing that the symptomatic tears did tend to progress. So if Sean can make you feel better with the small cuff tear and you have no pain, chances are you won't progress. It's the bottom line. But if you still have pain after rehab, so it makes our choice a little easier. So symptomatic tears progress. Also, more recent studies show in the very, very front end of the cuff is the key to vascularity. If that leading edge is fully torn, one study showed those patients go on to atrophy faster. So I look at the MRI, if they need one, if they got one, and I look at their shoulder and the response to therapy. And as someone who's a big believer in the importance of rest, I ask that person, I ask them a couple of key questions. Are you sleeping okay? Are you getting your rest? Number two, is this affecting your relationship with your spouse or partner? If you're a crank monster, then for gosh sakes, get it done. Yeah, number three, is your lifestyle impaired enough that you're not doing the things that really bring you joy? So some people want to play tennis. They can't play golf. They can't go to the gym and do light dumbbells. Those are things we really look into in our decision process. So I'd like to open the floor for questions, and I promised my wife I'd be home on time tonight. All right, I want to thank you for your attention, and there's going to be a party at Reggie's house afterwards. What are you serving, Reg? Guinness? Okay. Oh, you're welcome. You're welcome.